I will try to be fast because a lot of things already were discussed. Mostly to start with, I'd like to focus that in comparison to the previous talk, pediatric pulmonary LCH is usually the part of the bigger disease, multi-system disease, and I think this is the main difference, and also, but still can be very, very severe, for sure. And lungs are not treated as risk organs anymore, mostly due to the difficulties in analysis, in independent analysis. But however, some studies show that the lung involvement is not correlated with inferior survival. However, maybe they still should be. And here I start the series of Russian guy citing French papers, and there will be more of that. So this is a study showing that out of 17 patients who were admitted to ICU due to pulmonary LCH, 6 patients died. So 35%, which is an impressive rate, and to my mind, very, very hazardous. This is the continuation of the series, but this was already mentioned previously. So the pathology of PLCH is rather complex and involving the multiple forms of the disease, including the thick wall cyst, thin wall cyst, nodules. And recently there are more to analyze in genetics. So presented by the Dutch team, but also then confirmed independently by different other groups. Lung involvement in pediatric LCH is usually associated with deletions in BRAF 12 exon. And yeah, confirmed, our findings were also very similar. So pediatric PLCH is not considered as a high risk. However, the standard treatment is being applied to these patients across the world. However, patients may suffer from irreversible damage and even require lung transplantation. And V600T, which is well known currently and well studied, is less common in PLCH in pediatric pulmonary LCH without risk organs involved. So we decided to take a look if there is some ground for application of targeted therapy, different targeted therapy in pediatric pulmonary LCH. So to begin with, there are some scattered cases of such application, which show significant and not dramatic, as dramatic as for risk organs, efficacy of inhibitors. So we included patients less than 18 years old with suspected or proven lung involvement on BRAF inhibitors or MAC inhibitors therapy. We did the search in the database, and then also excluded the patients with less than 6 months of uninterrupted targeted therapy and less than 2 CT scan series available, which were then reviewed. Not all of them were reviewed yet, so we're in the process, but these preliminary results which we can show. So the scoring system was simple yet I think very comprehensive. So the one probably you well know, lung fields were divided for like 3 and 3, and cysts and nodules was scored independently. So this is the cohort characteristics, which are pretty in line with everything we know about these patients. Mostly male, mostly multi-system. Only one patient was single-system pulmonary involvement. Mostly risk organs minus. However, 5 patients were included with risk organs involvement. And you can guess the BRAF status pretty much. They were treated with vemurafenib, but other patients were treated with carbametinib or trametinib. And this was mostly applied as the second line of treatment. So pretty surprising that the relatively young age at diagnosis, 8 months. And the median age at inhibitor start was 18 months, with median disease activity score points at the therapy start 7.5. Obviously, in all cases, lungs were involved, but also skin was pretty often. And interestingly, 3 patients had thyroid involvement and pituitary stalk involvement, which is, I think, in this population is rather high number. And this is also might be connected with a different mutation status. However, these are speculations. So we had a chance to analyze. These are mostly French patients analyzed, but we have other patients from Poland, from also from Russia, from Argentina. So and these scans we will analyze a bit later. But what we see and what we observe, and this is also pretty much in line with scattered reports, that at the start and in the first 6 months, we can see the decrease in scoring for nodules, but not for cysts. For cysts, the median score even get higher, and then after 1 year plus and 2 years, due to probably once again the natural course of the disease, the decrease of the score can be achieved. So most of the patients had improvements, slow but steady. Some patients were stable, one was worse, but I will comment on that a bit later. And from the radiological point of view, this is also pretty observable, because, for example, here you can see this is at therapy start, and then you can see more cysts there, which then would recover on a very, very standard way. So, and this is more or less can be observable in different fields. So, yeah, this is more or less comparable to the natural course of lung repairment after the achievement of non-active disease, but still, all doctors who are dealing with such patients, they know that sometimes it's hard to understand and evaluate the response to, for example, even the standard conventional treatment, vinblastine plus prednisone, because cystic lesions can live a bit their own life, and this is sometimes hard to evaluate. Continuing. So one case, and this case was already described and published. One would expect just more time for the patient to recover with a severe cystic involvement, cystic damage. But over 18 months, as was described, 7 exacerbations occurred, with 1 leading to cardiorespiratory arrest. So sometimes, and some patients might just not have enough time to recover and to build back better with their lungs. And sometimes, so this might be suggestive for a bit early use of inhibitors. However, we should investigate this further. So to preliminary discuss that BRAF and MEK inhibitor therapy can be effective for the treatment of pediatric pulmonary LCH. And the nodular component seems to react much earlier, and cystic component show the improvement happens after years of treatment, which apparently is connected with the natural lifespan of tissue restorations. And in some case, the damage done might be irreversible, or the symptoms might severely affect the quality of life. In that case, different approaches might be found. However, we still have a lot of questions to discuss. How does the previous treatment affect the speed of lung restoration? What is the input and specific features of that can be caused by BRAF12 exon mutations? Is there a difference in inhibitors applied? What is the optimal starting time for the inhibitor application? And this might be the main question in that case. How should clonal eradication be achieved and controlled? This is, I guess, my favorite topic, as due to the combination of treatment of chemo and targeted therapy, but this is a completely different story. And there were reasonable doubts because we have a little cohort size and study design is pretty retrospective. The timing for the scans was not universal, so for some patients it was like a bit longer for the scans. So this is not absolutely unified. So the scoring system is easy and comprehensive, but still operator dependent. However, we didn't observe any major discrepancies between scorings from different experts, and no comparable data yet from the conventional treatment cohort. However, once again, referring to the report by Selene, that first-line treatment is usually, it might be not that effective for these patients. And the natural course of the disease is still, we know about this reluctancy and a bit later response. So this can also affect the study. So with that, I would like to conclude. And as Jean mentioned, I'm currently a bit culturally lost. So I've put many things there with different languages. Thank you very much.